Hello and welcome to How to Manage Shock, Part 1, Hypovolemic Shock. My name is David Woodruff. I am the editor of Critical Care Nursing, made incredibly easy. Hopefully, I can make this incredibly easy for you too. So let's talk a little bit about shock as a concept. When we talk about shock occurring in our patients, it's interesting, but if you look up shock in the, like Google it, for example, you're going to find lots and lots of definitions and pictures and so on of people being shocked. In other words, being surprised. Because we use that term all the time to talk about surprise. I was shocked to hear the news, we would say. When we're talking about shock here, we're talking about a different kind. This is physiologic shock that occurs in the body as a result of some condition, in this case, hypovolemia. Shock will result in decreased perfusion, and this is really the definition of shock. So for years we had other definitions. We used a definition like a low blood pressure as an example. So we would use that to define shock. But what we've found is that you can have a low blood pressure and still have perfectly normal perfusion. Certainly, you know people who are runners, for example, or athletes, and they have a very low resting heart rate and blood pressure, and there's no problem at all with perfusion. We can have somebody else who has a rather normal-looking blood pressure who has decreased perfusion, though, and that's how we define shock. Shock will result in organ dysfunction and death. So if we have this decreased perfusion for a long enough period of time, it's going to start causing organ dysfunction and death. Now, fortunately, we have some compensatory mechanisms in the body, and one of those compensatory mechanisms is going to switch us from having aerobic metabolism to anaerobic metabolism. So it will continue to maintain our organs for a period of time before we move into that situation where we end up having death. So let's take a look at this case study here. We have a 77-year-old female. She was admitted from a nursing home to the floor 2 hours ago with urosepsis. She was stable on admission but is now hypotensive and dyspneic. So we need to try and figure out why this patient is hypotensive. Now, with a diagnosis like urosepsis, certainly there could be more than one problem that is causing her to have hypotension. Let's take a look at her vital signs. Her blood pressure is 79/60. Her heart rate's 143. Respiratory rate's 35, and her temperature is 37.2. Her pulse ox is 94%, and she's on 2 liters by nasal cannula. Now, this could be a problem if this patient is already on supplemental oxygen and her pulse oximeter is only 94%. Then there is some kind of a problem. Now, a lot of times when we look at patients like this and we're caring for a patient and we say, well, her pulse ox is fine. It's 94%. But she's on oxygen. She shouldn't have to be on oxygen to maintain her oxygen level, her pulse oximetry. You don't have to be. As you walk around every day, you don't have to be on oxygen to maintain a pulse ox of 94. In fact, in most cases, most of us are probably wandering around now with a pulse oximetry of 96, 98% on no supplemental oxygen. So the fact that she needs supplemental oxygen to maintain 94% automatically tells us, hey, there's a little bit of something going on in her lungs. Now, she was admitted with urosepsis. No connection, right? Wow, that's going to come in part 3 when we talk about distributive shock, but there may be a little bit of sepsis and septic shock that's starting to develop. But in this case here, I'm thinking that she may be hypotensive as a result of maybe having some hypovolemia. Certainly with urosepsis, maybe she's not feeling very well, she's not drinking, or she's not getting any fluid in. So let's take a look and let's move on down this case study a little bit. So when we look at the different possible reasons for her decreased perfusion and her low blood pressure, one could be sepsis, one could be hypovolemia, Okay, so those are a couple potential issues that could be going on. Certainly, it could be cardiogenic. She's 77 years old. I mean, it could be a cardiogenic problem, but just given the information we have so far and this diagnosis of urosepsis, I'm guessing it's probably going to be hypovolemic. Now, how do I know that as opposed to septic? Look at her blood pressure. We're going to talk more about this in this series, but her blood pressure is 79/60. That is a very narrow pulse pressure. If you want to know more about blood pressures, go back and review our video about blood pressure and where we talk more detail about pulse pressure. But she's tachycardic. She has a narrow pulse pressure, probably hypovolemic. So what useful labs, tests, and vital signs would you like to see? Well, certainly I would like to see some additional vital signs as we continue to move forward with this patient to see if there's any improvement as we start to treat or if it's starting to decline and maybe we're missing the boat here. What useful labs? Well, what labs can we look at that would tell us that a patient is dehydrated? Now, if we're moving down that route where we're thinking, hey, this is sepsis, we're going to be picking up different labs and different tests than we would if we're thinking that this patient could be hypovolemic. Hypovolemic may be an H&H. Want to see where her red blood cell count is, where her hematocrit is, maybe a sodium level and some of our electrolytes give us a little better idea about fluid volume status. So the top three for this diagnosis, well, one might be, and again, going back to this idea here of the 94% pulse ox on 2 liters by nasal cannula, and the fact that her respiratory rate's 35, we might want to take a look at a chest x-ray. So let's put that in our, I would say, I would probably want to take that and put that in our top three. All right, then let's talk about the other one, H&H. That'll probably be in our top three, and maybe the electrolytes so that we can try and determine whether this is hypovolemic and what her fluid volume status is like. So what treatment needs to be started urgently? Well, I would probably say we need to start some IV fluids and see how that goes. Maybe give a fluid bolus, see if we have any improvement here in our blood pressure and our heart rate. What other diagnostic tests and treatment would you anticipate in this patient? Well, we may want to get some blood cultures. Again, going down that route of sepsis, we may want to start doing a workup for sepsis here and get some blood cultures. If we're going to draw blood for an H&H, well, we might as well draw a blood culture at the same time. So we might as well get that part out of the way too. Maybe we want to look at some urine. Maybe we want to look at some additional tests in addition to a chest x-ray. But certainly, I think those might get us moving in the right direction. So what are some clinical signs of shock? Now, this is shock in general, not necessarily shock from hypovolemia. Tachycardia, bradycardia. Ooh, wait a minute, bradycardia. Everybody knows about tachycardia, right? Tachycardia is a sign of shock. Yeah, we have tachycardia. Where does this bradycardia thing come from? Bradycardia can happen in neurogenic shock. Okay, so this is the piece that doesn't fit. You have a patient who's hypotensive and bradycardic. Those two things don't fit together, hypotension and bradycardia. That's a big red flag, neurogenic. Look for the neurogenic shock. Altered level of consciousness. Okay, as we get decreased perfusion, we have decreased perfusion of the brain, and we start to decrease the level of consciousness. A increase or decrease in blood pressure. Wait a minute again. Okay, now, shock is a decrease in blood pressure. We all know that, right? What's this increase in blood pressure thing going on here? Well, we can have an initial increase in blood pressure again, going back to sepsis. There are 2 stages of sepsis, and we're going to talk more about this again. So make sure you're tuning in for section 3. But in section 3, we're going to talk more about sepsis and how we have a hypermetabolic state that precedes the shock state. Increase in respiratory rate and dyspnea. We see that in this patient. She has an increase in respiratory rate. Decrease in urine output. Now, certainly that could mimic somebody who has urosepsis. The diagnosis was made of urosepsis in our patient, so maybe we already do have like some urine back or something like that, so that we know that it's urosepsis. Diaphoresis, pallor, cyanosis, decrease in our SVO2. That is our oxygen, a measure of, I should say, our oxygen consumption. So that'll start to decrease because we have more consumption at the tissue level, so there's less left over. Hypothermia and fever could be signs as well, depending on where we're at with our septic shock. So stages of shock, and we see this really pretty well in our patients who have hypovolemic shock. There's this early stage of shock. In early stage, we have these compensatory mechanisms starting to kick in. Not a lot, so you don't see a lot of difference. If you don't drink anything all day, you're working a 12-hour shift, you're just running around all day long, you don't get a chance to drink anything, certainly by the end of the day, you're not going to have a lot of urine output because you didn't take anything in during a day, right? So during that time, what your body did is it turned on some compensatory mechanisms in order to try to hold on to the fluid that you already have. And that's why the urine output is low, is because you've been hanging on to fluid. At the same time, we might have had just a little bit of an increase, little sympathetic nervous system stimulation, a little bit of an increase in your heart rate and blood pressure in order to maintain perfusion. That's early shock, okay? So the next time you're told that you can't take a break during your shift, just let your boss know, hey, I could be going into the early stages of shock if I don't get something to drink. I don't know if that'll work or not. Anyway, so let's move into the next stage then. And in the next stage, we have compensation. Clear clinical signs of compensation. So that would be tachycardia, decreased urine output, maybe some diaphoresis, cool, clammy skin, pallor, all those kind of things, right? Those are all signs of compensation. During that compensatory phase, we have cellular dysfunction. Now, the cells are not dying yet, they're just having dysfunction. So all of the cells of the body won't work quite as well as they should, including the cells in the brain, so we might start to get some confusion, some lightheadedness, things like that. Other cells in the body aren't going to work as well either. The cells of the heart, the cells of the kidneys, the cells of every organ in the body is going to start to have some dysfunction because we are not perfusing the cells. But compensation is still keeping those cells alive. Next, we move into the progressive state. Now we start to get organelle damage. Now you notice as we go across this screen, you notice that those circles are getting bigger. So the circles are illustrating a cell. And what happens is as those organelles start to become dysfunctional, so in the compensatory state we have dysfunction, then we have damage in the progressive state. As those organelles start to become dysfunctional and then become damaged, we can no longer run the sodium-potassium pump like we should. Sodium rushes into the cell, water follows it, and the cell will swell. Now, eventually, there's going to be so much water in the cell that the cell will burst and we'll have cell death. So we want to try and stay away from getting way down this road here. Now, during the compensatory stage, remember I said compensation works. We're maintaining those cells. Blood pressure is still maintaining. Progressive is when we start to see the drop in blood pressure. So if we're waiting for a drop in blood pressure to say, hey, I think this patient's developing hypovolemia, then we're waiting pretty far down this road, and there could already start to be some cellular damage. And when you look at this chart here, you notice down at the bottom it says early, compensatory, or reversible, totally. No problem at all. Give some fluid, we're right back there, right? Progressive stage, it depends on a lot of things. What is all the underlying illness of this patient? Do they have a lot of, maybe they've got diabetes and they have peripheral vascular disease and they have some organ dysfunction already. Maybe they've had a couple MIs and things like that. The more underlying disease that this patient has, the more the organelles are going to become damaged because they're kind of friable to begin with. and then we cut off some of their oxygen supply, and whoa, then now we're really in trouble. Finally, we move over to cell death, and that's irreversible. Well, when the cell dies, it dies. I mean, there's nothing you can do about it. It's dead. Now, if this is 1 million cells in the kidney, we're going to have kidney failure. If this is 1 million cells in the brain, we're going to have anoxic brain injury. So we want to stay away from progressive refractory. Certainly in progressive, now is the time we need to treat and treat fast, move this patient back out of that stage so that hopefully we'll have as much function preserved as possible. Now, I mentioned compensation a couple times already. There are 3 major systems that are involved in compensation. The first is the sympathetic nervous system. The sympathetic nervous system is your fight or flight response. And this will kick in, it'll cause vasoconstriction and increase the force and the rate of contraction of the heart so that we have the heart beating harder and faster. We have vasoconstriction in the vasculature, and that helps to maintain blood pressure. We have the renin-angiotensin system kicking in, causing vasoconstriction and fluid retention. Okay, that's a good thing. Hang on to some fluid. Aldosterone's kicking in, causing fluid retention. Great. We're hanging on to fluid. We're increasing the force and rate of contraction. We're causing vasoconstriction, and all those things help to maintain blood pressure. So it's these compensatory mechanisms, and they actually work in hypovolemia. You'll see in part 2 and part 3 that these compensatory mechanisms don't necessarily work well when it's cardiogenic or when it's septic. So, does an increase in blood pressure equal an increase in perfusion? If the blood pressure is being increased by these compensatory mechanisms, are we necessarily getting an increase in perfusion? Notice all that vasoconstriction that's going on? We're increasing blood pressure to try and save the vital organs. So hypovolemic shock is going to be defined by having a lack of circulating volume, either from hemorrhage, dehydration, burns, third spacing. But remember again, compensation works. All of those compensatory mechanisms help in hypovolemia. Now here is the thing that we want to avoid. So we call this the trauma triad of death. Hypothermia, acidosis, and coagulopathy. These things are going to occur when we get to that refractory stage. And this is why we cannot reverse that. When we have coagulopathy, which is causing little microclots in the circulation, that's blocking off perfusion to our organs. When we have acidosis, and the acidosis is causing dysfunction of the organs by itself without having decreased perfusion. And then hypothermia. So this triad is going to be one of the things that is going to determine whether or not we move out of that refractory state. If we're in that refractory state and we don't have these things, or we don't have all 3 yet, then it's possible we can move back out again. But if we got all 3 of these, chances are very good we're not moving back out again. So staging the volume loss, if you take a look at the different stages here, a volume loss of about 15%, 10 to 15%, we have an increase in heart rate, but blood pressure is going to remain normal. Okay, now again, think about those compensatory mechanisms. The heart rate's going up because the sympathetic nervous system's kicking in. Sympathetic nervous system is increasing our cardiac output because it's increasing heart rate. We have a normal blood pressure because of vasoconstriction and that increase in heart rate causing an increase in cardiac output. When we get to the 15 to 30%, now you see we start to decompensate. We still have some perfusion going on here because we have compensation. Heart rate's going up, cardiac output's starting to drop, blood pressure's starting to drop, because we reach a point where increasing the heart rate is not going to help. All right, well, think about it like an IV pump. If your IV pump, if the bag is dry, turning up the rate on the pump doesn't help. We need to put another bag up there, right? It's the same kind of thing that happens in hypovolemic shock, is that if we don't have enough fluid to pump, increasing the heart rate isn't going to help anymore. And that's when we move into stage 3, is when the compensation fails. So now the blood pressure is going down, it's going down, it's going down, and the patient is not being helped by the compensation anymore. Lastly, we get to greater than 40%, and now this patient is critical. The compensation has failed. We're going to have really low blood pressures, if there's any blood pressure at all, and that patient is going to either need immediate surgery or something to stop the bleeding and replace the volume, or that patient's going to die. So what's our treatment? Well, we have 3 main options here. We have blood products, we have colloids, we have crystalloids. You may notice the little call out here at the bottom left, saying vasopressors may hide the hypovolemia. So vasopressors are a possibility to try and increase our blood pressure. But if there's nothing to pump, there's nothing to pump. So you have to be careful with that. In some cases, we may want to do a very gentle resuscitation. So we may use some vasopressors to increase the blood pressure slightly while we are doing our gentle resuscitation. So maybe your patient's got a really bad heart but has a real volume deficit. We need to replace the volume, but if we dump in a couple liters and a couple units of blood, they're going to go right into pulmonary edema and heart failure. So in that case, maybe we want to use a little vasopressor to maintain our cardiac output and then gently resuscitate. So our blood products, we have some different options here: packed red blood cells, platelets, FFP. In our colloid group here, we have some different options too. Colloids may decrease the risk of pulmonary edema because they have this osmotic pull that's going to pull fluid into the intravascular space. Crystalloids, on the other hand, only remain in the bloodstream for about an hour, after which they're going to move out into the interstitial space. They can also result in hemodilution and actually decrease the amount of delivered oxygen that we're giving. So we want to be careful. You dump 5 liters of saline or lactated ringers in somebody, and we can end up having hemodilution, and then an hour later we have to give more blood, we have to give more crystalloids, or we have to give blood or something else because the crystalloids went into the tissue. Well, thank you for joining me for How to Manage Shock Part 1, Hypovolemic. I hope you'll be looking forward to our next couple of sessions here with cardiogenic shock and with distributive shock, including septic shock. Thanks again for joining me today, and until next time, bye now.